Hey guys, it's Medicosis Perfectionalis one more time, continuing our great playlist on pulmonology. Today we'll talk about Neonatal Respiratory Distress Syndrome, or NRDS. Mommy has diabetes, for example. Mommy is having hyperglycemia, thumbs up, but the baby is having hypoglycemia, thumbs down. This baby has lots of insulin. Insulin inhibits the production of surfactant. When you have less surfactant, you have higher surface tension, you have a higher likelihood that your lungs may collapse. With that being said, now let's get started. In the previous video, I've talked about surfactant, which is anti-surface tension. Highly recommended that you watch the previous video before watching this video. As you know, the alveolus has type 1 pneumocytes for gas exchange and type 2 pneumocytes for surfactant production. This yellow line is the surfactant creating an interface between the air here and the water here. When you separate the air from the water, you decrease the surface tension and you protect your lung from collapsing. We have talked about lecithin sphingomyelin ratio before. Normally, if we're talking about after 28th week of gestation, it should be 2 or higher. Neonatal Respiratory Distress Syndrome, also known as hyaline membrane disease, there is decreased surfactant, increased surface tension, the lungs are more likely to collapse. Causes: prematurity is the most common cause, especially less than 28 weeks of gestation. Incidence is inversely proportional to the gestational age. Let's say that the baby reached 40. This is a higher gestational age, therefore lower incidence of neonatal RDS. Same thing with birth weight. The higher your birth weight, the less the incidence of neonatal RDS. Diabetic mother is an important cause, and we'll talk about this in the next slide. In brief, mommy has hyperglycemia, right? Right. Okay, let's say that mommy has type 2 diabetes, so she has some insulin, okay? But the insulin has insensitivity or decreased tolerance to glucose. Therefore, mommy cannot use the insulin, but the insulin is there. Glucose can pass through the placenta, but insulin cannot. So mommy can only give some glucose to the baby. She cannot give him or her insulin. The baby develops hyperplasia of the pancreatic beta cell to counteract this glucose. This is going to increase insulin secretion in the baby. He didn't get it from mommy, he made it himself, leading to hypoglycemia and decreased surfactant production in the baby. Therefore, his lungs are more likely to collapse. Next, C-section. Why? In normal delivery, like vaginal delivery, while the baby's head is being squeezed through the vaginal canal, the skull is squeezed and there is increased stress. And the major stress hormone in your body is cortisol. When you have stress, cortisol goes up to counteract the stress. Cortisol increases surfactant production as we multiple births, asphyxia, precipitous delivery, which results in a very rapid labor. Maternal history of NRDS. Again, the best predictor of future behavior is past behavior. If you have been an honest person for 40 years, you're more likely to be honest in the next year. But if you are a scumburger for 30 years, you're more likely to be a scumburger in the next year. The best predictor of future behavior is past behavior. Same thing with risk factors. If I had 3 heart attacks before, and I'm having cardiac chest pain now, odds are it's a heart attack. Here is the story of the diabetic mother. Here is mommy with hyperglycemia. She has hyperglycemia. If she has type 2 diabetes, probably insulin is normal or increased. If she is type 1, insulin is decreased. Okay, only the glucose can pass through the placenta, the insulin cannot. Glucose passes through the placenta, goes to the baby's blood. Baby is going to respond. Hyperplasia of the beta cells in the islets of Langerhans in his pancreas, leading to increased insulin secretion. And when you increase insulin secretion endogenously, you will increase the C-peptide. Increased insulin will lead to decreased surfactant, increasing surface tension, neonatal respiratory distress syndrome. Increased insulin is going to feed the fat, getting glucose into the cell and getting potassium into the cell. The baby will end up with hypoglycemia and hypokalemia, and since we are feeding the fat, the baby is going to have increased body weight. One of the causes of increased body weight in a newborn is a diabetic mother. I hope this makes sense. To prevent neonatal distress syndrome, give one of the 3 hormones that stimulate surfactant: glucocorticoids, thyroxine, or prolactin. No surfactant increases surface tension. Increased surface tension, atelectasis, leading to perfusion without ventilation, leading to a VQ mismatch. On gross examination, gross here doesn't mean disgusting, it means on large scale, opposite to microscopic. Grossly, when you look at the lungs are known to be dark and airless. Why airless? It has collapsed, baby, due to lack of surfactant, due to increased surface tension. This lung has no residual volume or minimal air. If the lung collapsed before the baby breathes in any air, that's gonna lead to a lung that's dark and airless and has no residual volume and no minimal air. On autopsy, the lung will sink in water, and I've talked about this before. If the baby died before breathing in any oxygen or any air, this is what's going to happen. You get a piece of his lung and put this lung in like a glass of water, it's gonna sink to the bottom. Why? It doesn't have any air. No residual volume and no minimal air. But if this baby was born alive and then killed, the lungs will float because they have minimal air. It's gonna float, and that's how forensic pathologists argue in court cases. On microscopic exam, this lung is collapsed, alveoli are collapsed with atelectasis, damage to the pulmonary vessels, leakage of proteins stained pink on H and E, alveoli are lined by pink or hyaline membrane. It's not actually a membrane, it's like lots of pink substances like this. When you look under the microscope, if you are not very sophisticated, you'll see, oh, it looks like a membrane. That's why they called it hyaline, which means pink, membrane disease. What are the clinical manifestations of a baby born with respiratory distress syndrome but he's alive? Okay, all right. Early onset tachypnea within minutes. Ooh. Later onset tachypnea, think other condition. For respiratory distress syndrome, the tachypnea has to be early. Respiratory difficulty, no wonder we call it respiratory distress syndrome. There is no surfactant. Prominent grunting. If you want to listen to the voice of grunting, you should Google it. Intercostal retraction due to respiratory fatigue. Nasal flaring, hypoxemia, hypercapnia leading to respiratory acidosis. The guy's not breathing. Edema. Harsh tubular breath sounds could be normal or could be diminished. Normally, when we put a stethoscope on the lung, we do not hear tubular breath sound, we hear vesicular breath sound. They sound like this. Those are vesicular. But in cases of respiratory distress syndrome, they are tubular. Why? Okay, let me explain this. We have two types of waves. We have mechanical waves, let's go back to physics, and we have electromagnetic waves. Mechanical waves such as sound. Electromagnetic waves such as light. Got it? Okay. Light travels better in air, better than water, better than solid. Sound is the opposite. It travels better in solid than water than air. If you replace the air in the alveoli with solid membrane called hyaline membrane, you will increase sound conduction. That's why now the sound is not vesicular, it's tubular. And it sounds like this. This is the tubular sound. What else? Fine inspiratory crackles. Crackles, okay. I'm an Egyptian guy, so I'm the best guy, like the most qualified to explain this to you. Crackles happen when you have air and water mixed together. There is a device in Egypt called the hookah, okay? I don't know why people do this weird thing, but they do it. Hookah is actually some water, and I believe it has some nicotine or something like that inside of it. All right, and then they give you like this kind of a hose, and you smoke. So it has water, it has air. Water and air equals bubbles. They are going to form bubbles. The sound when you inspire and inhale and suck in this hookah or this disgusting, unhealthy stuff looks like crackles or sound like crackles, like this. Here are some crackles. Let's do it with inhalation. Inhalation. Exhalation. And by the way, these hookahs have flavors. They have apple flavors, mango flavors, etc. When Sir Isaac Newton saw an apple, he discovered gravity. When Steve Jobs saw an apple, he created Apple Incorporated. When Egyptians saw an apple, they created a hookah with an apple flavor just to demonstrate crackles. Anyways, progressive worsening of cyanosis and dyspnea. It's called respiratory distress syndrome. If you're not breathing, you will get cyanosis. Hypotension, apnea, irregular breathing. Intraventricular hemorrhage, the kid can bleed into his or her brain. How to diagnose neonatal RDS, ABG. Why? Because there is hypoxia, there is hypercapnia, there is respiratory acidosis. In respiratory acidosis, pH is low. That's the definition of acidosis. In respiratory acidosis, PCO2 is high. That's the definition of respiratory acidosis. The kidneys are trying to compensate. Respiratory acidosis, let's make a metabolic alkalosis to compensate. How do you want to do an alkalosis? You do an alkalosis by increasing the base or the alkali and increase bicarbonate. Radiology, chest x-ray, ground glass appearance, very important. Fine reticular granularity of the parenchyma and the air bronchograms due to the destruction and the hyaline membrane, stuff like that. Biopsy, you see a beautiful, not so beautiful, pink hyaline membrane. It's pink because it has proteins, and as you know, proteins stain pink. Complications of neonatal RDS. Death. Could be perinatal or neonatal. Both NRDS and ARDS lead to respiratory acidosis or respiratory alkalosis, because it depends on hypoventilation or hyperventilation. If the kid is tachypnic, it's going to be respiratory alkalosis. If the kid is not breathing, respiratory acidosis. Oxygen toxicity, because this kid is going to get oxygen. We're giving him oxygen, but too much oxygen can lead to free radical damage of the lungs, the retina leading to blindness called retinopathy of prematurity, and small airway called bronchopulmonary dysplasia, which could be permanent, which is bad. Patent ductus arteriosus. This ductus arteriosus should close. When should it close? It should close when the kid breathes in. What closes it? The oxygen. But in respiratory distress syndrome, there is no oxygen. The patent ductus arteriosus is not going to be closed like normal people. It's going to be persistent ductus arteriosus or persistent PDA leading to. Those are some complications of neonatal RDS. We continue. Necrotizing enterocolitis or NEC. No ventilation, therefore low P big AO2, therefore low P small AO2. We have talked about this in previous videos. Intestinal ischemia, entry of gut bacteria, because some of these bacteria are anaerobes. They hate oxygen. When they hate oxygen and you don't have oxygen, they're gonna love you. And they're gonna go to your gut, and those bacteria are not pretty, and they will lead to necrotizing enterocolitis. And if you do radiography on people with necrotizing enterocolitis, you find something called pneumatosis intestinalis, which sounds exactly like medicosis perfectionalis. I have a lovely name. Pulmonary hemorrhage or interventricular hemorrhage, those are complications. Alveolar air leak leading to air under the skin, emphysema, air in the pleural cavity, pneumothorax, edema, ileus, oliguria, because urine volume is the fifth vital sign if you are sophisticated enough. Fetal hypoglycemia despite maternal hyperglycemia, and we have talked about this before. Hypoglycemia is going to lead to seizure and neuronal damage, decrease surfactant production leading to neonatal RDS. If grunting disappears and cyanosis increases, the baby is getting worse. But the grunting, the bad sound, is disappearing. Yes, that's why the kid is not breathing. It's not good news, honey. Think. The kid was doing this, and now he's like this. Oh, the sounds disappear. Yes, but his life could disappear soon, unless you act quickly, doofus. How to prevent neonatal RDS. Avoid unnecessary C-sections before the 39th week. And as Dr. Thomas Sowell, the famous economist at Stanford University, said, in life there are no solutions, there are trade-offs. C-sections are excellent, okay? They are revolutionary. Although they are not that new, they are kind of C-section due to Caesar. So it's not that new. So it's great, but every great thing has great side effects. C-sections, there is no passage through the birth canal. There is no stress. There is no cortisol. There is increased risk of neonatal respiratory distress syndrome, especially if he or she is premature. Antenatal steroid prophylaxis. Steroid increases surfactant production. Antenatal, before childbirth, give steroid to mommy. Given to women before 34th week of gestation. Betamethasone or dexamethasone. Before 34, during the 34th, it doesn't matter. This was prenatal. Also, we have postnatal surfactant administration, and we administered it through the trachea. Give steroids plus surfactant, hashtag synergism. Synergism means 1 plus 1 equals 3, which is a mathematical insanity, but a pharmacological reality. Prevention of complications, give glucose if the kid can suffer from hypoglycemia. You give glucose. How to treat neonatal RDS. This kid is gonna stay in the neonatal ICU, also known as NICU. I'm sorry, this kid is not going home, okay? No matter how much you tell me this, I want to take this kid home. No. He has neonatal RDS, has to stay in the NICU. We will administer surfactant directly into the trachea, continuous monitoring of ABG, heart rate, respiratory rate, signs, and we will monitor cyanosis and grunting. If cyanosis increases and grunting is decreasing, bad news, and we should intubate. Arterial cath, touch times with mommy, skin-to-skin contact. Get this kid close to mommy. Human beings are not moist robots so that you can treat in the lab. No, skin-to-skin contact with mommy. Why does that happen? There are some theories, but the exact mechanism is not fully understood. But when you keep the kid closer to mommy, he's gonna get a better outcome, hopefully, many times, in many cases. But if you get him closer to daddy, worse outcome. It's a silly joke. Place in an incubator if necessary. Give warm, humidified oxygen. Yes, because there is a VQ mismatch due to hypoventilation or due to the stupid membrane. So the problem is not a shunt, okay? There is not an intracardiac shunt where oxygen is useless. No. In this case, oxygen is helpful. Watch my videos on tissue hypoxia. Okay, some pearls for the pros. Maternal diabetes, increased risk of all of this. Neonatal RDS, neonatal hypoglycemia. Why? Because insulin in the baby due to hyperplasia of the pancreatic beta cells leading to hypoglycemia. We have discussed this in this video. Hypocalcemia, polycythemia. Why polycythemia? This is an appropriate increase in EPO. This is secondary polycythemia, and it's an absolute polycythemia. It's not a relative. Macrosomia, this baby has increased body weight. Why? Because insulin feeds the fat. Myocardial dysfunction, jaundice, congenital malformation. Oh, horrible. Macrosomia, insulin feeds the fat. Insulin feeds two main tissues. Adipose tissue, skeletal muscles. How? Remember GLUT4, which is insulin dependent. Every other GLUT is insulin independent. Twin gestation complications. Compared to the firstborn twin, the second twin has a higher risk of neonatal RDS and asphyxia, which is bad. By the way, talking about the firstborn and the secondborn, on average, not talking about twins, talking in general, the firstborn has a higher IQ and a higher body weight than the secondborn or the thirdborn or stuff like that. When I first heard or read the study, I was amazed because I'm a firstborn. While I don't know the IQ of my brothers, I'm pretty sure I have more body weight than them. I'm more obese than them. They are thin. And here is a challenge for you. Those of you who think that genes and environment can explain everything, okay, explain to me why the firstborn is on average a little smarter than the others. They have the same genes because they came from the same mommy and daddy, and they had the same environment. They were born in the same household. They went to the same school, probably lived in the same neighborhood. So explain to me why the first one has increased IQ. Some inspiration. If you believe that if you have a low IQ, you're doomed, okay, listen to this. There was a professor at Stanford, and he was looking at the physics students in Stanford. And he was looking at people who had IQ greater than 140 and IQ less than 140. And then he followed them for 50 years. And he found that 2 of them were awarded the Nobel Prize in Physics. The 2 were of IQ below 140. You know how many got Nobel Prize from the group which has an IQ of greater than 140? The answer is 0. So the idea, oh, my IQ is low, I can never make it today. Wah! Call the ambulance and cry me a river. As Henry Ford said, whether you think you can or you think you can't, either way, you're right. It's up to you guys. And as Walter D. Wintley said, life's battles don't always go to the stronger or faster man, but sooner or later, the man who wins is the man who thinks he can. Thank you for watching. Please subscribe and join the tribe. Hit the bell to get notified and smash like. Follow me on Facebook. I have more than 100 cases there. You can get my premium videos, my cases, my post notes, my audio notes, and my PDF organized in Dropbox folders available for direct download, and you can keep for you forever. Thank you for watching. As always, be safe, stay happy, and study hard. This is Medicosis perfectionalis, which sounds exactly as pneumatosis intestinalis that you see in necrotizing enterocolitis. See you then.